Ẹ káàárọ̀ o.
Ẹ káàárọ̀, my PhD.
Ló ń kó sí wa pa. Káàárọ̀ sísá.
Báwo ni?
Káàárọ̀.
Báwo ni?
Adúpẹ́ fọlọ́run. Iṣẹ́.
See you later.
You sound so tired, pẹ̀lẹ́.
Yeah.
Morning, ma.
Good morning. My PhD. Oshi Onibosi, how you doing? Good morning.
Àlàáfíà, ma.
Captive. Oh,
Ẹ ǹlẹ́, ma.
family ńkọ́?
We bless God.
And the
Good morning, everyone.
good morning. How are you?
I'm fine, thank you. And you?
I'm good too. My presido.
My bed, where are you going this early morning?
I'm in my own car. Just walking around, taking some walk.
Okay.
Yeah,
Well done, ma.
thank you.
There's no artificial light in the drone. He turns around.
Good morning, everyone.
Good morning, PDGBO.
Looking at each other like we're not anxious.
All right.
He's
Okay.
here.
Good morning, everyone.
Not my PDG, sir.
All right. Good morning, Madam DG.
Good
We should
morning.
start very soon. Just waiting for the facilitators to come online. Been trying to reach them. And soon they will join us. Just give a few minutes, please, before we start. Thank you very much.
How do you think all this can go in?
Back going to very car. Wow. All the back. All back.
Let me take this one back.
People made that against me. Yeah, I didn't sleep on that.
Good morning, distinguished Rotarians.
Good morning, my
Good
PP.
morning to you, Doctor.
How are you doing?
I'm good. My PAG. Good morning, ma.
Good morning. Well done,
Rotarian
my
Innocent. Good
dokie.
morning, sir.
My dokie
Good
dokie.
morning to you, Doctor.
Yeah, nice to be with you all.
My CMP.
Yeah, I greet you.
Yeah, good morning, Dr. Bartholomew.
Good morning, sir. My PGD.
Okay,
I
thank you
greet
for
you,
coming
sir.
online. Yeah,
Thank you,
yeah,
sir.
you're welcome. We've been trying to reach you.
Sorry, I have to refresh my Zoom. It took me a
Okay,
while to do so, but I'm good to go.
all right. I think we should just start in earnest. You are here right now. While we are with Dr. Festus to join us later, All
Okay,
right.
sir.
So let me call on my DG. Madam DG, are you there, please? So we don't waste people's time. We have about almost 20 people online. Madam DG, good morning, ma'am.
Good morning, my DLF. Good morning.
Yeah, good morning, Madam DG. And good morning, fellow Rotarians. This is the first of the learning series we'll be having in this Rotary year. For me, I'm particularly excited that the year has started in such an exciting way. And it's looking more like Madam DG has spent close to like 2 years on this job. Madam DG, we want to congratulate you and thank you for everything you've been doing so far. I recognize all our Rotarians that are here on this platform, particularly our district leaders that are here. And let me recognize also especially our Assistant Governor, Doyin Adebayo, all the way from the UK, so the Rotary Club. Rotarian Kate, we can see your beautiful face. Thank you very much. Thank you very much also for joining PAG Busola Satue. And I should not forget all my people at the back end, all the core team members. Our district treasurer is on the call. And our PDG, Kennedy Ejakwemewe also, I saw him earlier. Yes, he's still there. PDG Kennedy, we want to thank you also for being on this call this morning. Fellow Rotarians, this is the first of the learning series. We'll be having this Rotary year, and it's going to be a monthly thing. We want to ask you to please.
Children mean healthy families and healthy communities, and ultimately a healthy nation. When you look at it, every mother deserves the joy of holding a healthy baby. And every child deserves the chance to celebrate a first-year birthday, a fifth-year birthday, and many more birthdays to come. Sadly, for too many families, that isn't yet the reality. But the good news is that Rotary has never been known for watching problems from the sidelines. We usually will roll up our sleeves and get to work. And today's seminar is an opportunity to learn, exchange ideas, and discover practical ways our club can save lives and improve the well-being of mothers and children in our communities. I know that a couple of weeks ago, we held a seminar on the same subject. But please don't forget that on a daily basis, women will get pregnant, babies will be born. So I encourage everyone to stay engaged, ask lots and lots of questions, share experiences, take notes, and please don't disappear after switching off your camera. If you're, of course, everybody is joining us online now. We can usually tell when you switch off your camera. Anyway, as we continue our journey of creating lasting impact, please let us remember that every safe delivery, every vaccinated child, every health education program, and every maternal health initiatives is another life touched and another family straightened. I want to thank our facilitators for giving their time and their experience. And thank you to every participant for choosing to spend your Friday morning with us. Have a wonderful seminar, and may today's discussion inspire even greater service in our clubs. Thank you, and God bless you all.
All right, thank you very much for that, Madam DJ. And without wasting so much of our time, the first facilitator, Dr. Bartholomew of the Rotary Club of Ikeja South, will lead us on the topic, prioritizing the healthcare of mother and child. You have the floor, please. Past President Bartholomew.
Good morning, my BDG. Please, I would like to have an idea of how many time I have so as to not know how to structure my time. What time is available for me, sir?
20 to 25 minutes.
Okay, fantastic. Thank you very much. My
Yeah, you're most welcome.
district governor, distinguished club leaders, district leaders here present. My name is Dr. Bat Tochukwu Febuna. I'm the medical director of Grace Valley Medical Center, Lagos State here, Okota precisely. I used to be also the presenter of Health Matter. I used to be the presenter of Health Matter on DSTV, a program I ran for almost 10 years, but we are on break now. So I dare say that this is a familiar terrain for me. Now, without much ado, when we talk about prioritizing maternal and child health, I think a convenient point to start with will be from childbirth. Okay. Now, for mothers to give birth to healthy babies, they must ensure that their nutrition is adequate. So everything starts from the point the woman takes in. And of course, for those of us who may have given birth among us here or who are ladies, you will know that your last menstrual period is a major landmark when we talk about pregnancy. So pregnancy is actually dated from one's last menstrual period. And pregnancy, as we always say, is a 40 weeks course. But traditionally, we are told that it is 9 months. But when you do a small permutation, you realize that 40 weeks is actually beyond 9 months. Okay, so from LMP to the date of delivery of the baby is a period of 40 weeks from medical perspective. Now, the first challenging time in pregnancy is actually the first trimester of pregnancy, which a lot of school of thought has defined as the first 13 weeks of pregnancy. So pregnancy majorly is subdivided into 3: first trimester, second trimester, as well as third trimester. Okay, in that order. So the first trimester is usually the most challenging time in pregnancy. That's actually when mothers or potential mothers or pregnant women, some may get into trouble. Usually at this time, they may lose their baby, they may start spotting. Oftentimes, it may end up in a miscarriage. So a whole lot needs to be done at this point. Okay, so one of the things that we usually will advise pregnant mothers to do is to ensure that they take their routine drugs. Those multivitamins that we usually give to them when they are pregnant, very, very important. Okay, because if you fail to take those drugs as advised, you may end up giving birth to babies that could have some form of spinal cord problems or congenital malformations, as we say in medical practice. Spinal cord bifida stands out, okay, because a whole lot of time we see such complications arising. And just doing a whole lot of vegetable diet when one is pregnant, or ensuring that you take your routine drugs while pregnant, can actually save you from this danger. And spinal cord bifida, if I must bring it out so that we can all understand what I'm talking about, talks about giving birth to a child that has a hole at the back of the spinal cord. Okay, so even if you're a very rich person and you probably make out a check of 10 million, I can assure you that before that child gets to 5 years, your 10 million will be gone, because it involves a whole lot of things. And these are something that can easily be preventable by ensuring that the woman, while pregnant, takes her routine drugs properly. Okay, so that is very important. It also helps to guard against anemia in pregnancy. Usually, for pregnant women, once they become pregnant, their blood levels will start to drop because of the additional requirements that their system may be needing because of the pregnant status of such individual. So those routine drugs will also help you to avoid becoming anemic. Very recently, I had a delivery in my facility that we had to transfuse a pregnant mother under a space of, she was actually carrying twin gestation. That's twin pregnancy. So we had to transfuse her with 6 units of blood, 6 pints of blood, under a space of just 2 months, to ensure that she at least get to the to safer ground before we could take delivery of those babies. But thankfully, the delivery and everything went well. Our mother and child are doing fantastically well. They should be about 4 months now. She shared pictures recently with us to encourage us in what we're doing. So anemia needs to be guarded against when one is pregnant, because it can actually cause abort the pregnancy, it can actually also cause IUFD, intrauterine fetal death, in which case a child may die in the womb as a result of not having adequate nutrition. So this needs to be guided. That's for pregnant mother. Okay. Now, after the first trimester, you get into more or less the second trimester of pregnancy. In the second trimester, it starts from the second 13 weeks of pregnancy. During this time, there are some precautions that any pregnant woman will actually need to take during this time. One of them is the fact that being in this part of the world where malaria is endemic, is also as the second trimester of pregnancy that we treat women for malaria. We do what we call intermittent preventive treatment for malaria using intermittent preventive treatment for malaria, IPT. Usually we give a common drug that all of us will know here, sulfadosine pyrimethamine. If you can remember fasting of the olden days, they are no longer in Nigeria, but what has replaced them is a brand called Swida. That is all you need to give when a woman is between 17, 18, and 19 weeks of pregnancy. So you can give that. That is what we usually use to do intermittent preventive treatment for malaria. Also important is that the pregnant woman must ensure that she takes anti-tetanus injection. We have different formats. Back in the days, we were taught in school that the woman does 5 doses over a space of 2 to 3 years. But when we realized that people weren't sticking to that order, we just made it possible to ensure that any woman who's pregnant gets at least nothing less than 2 doses of anti-tetanus injection. Now, this is important because tetanus can actually happen in the course of delivery. A whole lot of women that are pregnant may not end up delivering in hospital settings. They may end up delivering in traditional birth attendants. So we also have to tutor those people to ensure safety of the mother and baby. Another thing that is very important that I must also say at this stage of pregnancy is what we call anomaly scan. Usually when the pregnancy is halfway gone, every pregnant woman should go for an anomaly scan. If your doctor hasn't sent you for one, please ensure that he or she does so. That anomaly scan is actually the scan that can pick out if the babies are having any form of congenital malformations in the course of developing in utero, that's within the womb. If you notice any, it can actually help you to know what direction to go. What are common complications that you can have at this stage? You may have babies developing with what we refer to as anencephaly. Baby will be developing without brain. You will have a skull, but there won't be any brain, and you will have bulky eyes. Okay, I've encountered that twice in my practice, and we're able to dictate it because we did a anomaly scan when the pregnancy was halfway gone, usually at about the 20th week. Okay, so what we did was to advise the mothers, when you discover that abroad, if you venture take a delivery and bring out a baby with congenital malformation, you can actually go down for it. Okay, so you need to inform the person that the baby you're carrying may be having 1 or 2 congenital malformation ahead of time for safety, for everybody's safety. Okay, so we advise. There were 2 scenarios I want to. One of them was in a hospital I used to work with somewhere in Agoda. Okay, so we advised the mother that the baby she was carrying had an abnormality that may not be compatible with life, a congenital abnormality that may not be compatible with life. But because she was looking for a male child, regrettably, that baby's sex was also male, and this woman has had 4 babies prior to that time. So she refused to terminate the pregnancy. Okay, so what happened is she carried the pregnancy to term, and we delivered the baby vaginally. By the time we did, the baby came out within a space of 1 or 2 seconds, opened those eyes that were looking like an adult eyes. Please, I'm not laughing, but these are realities of life. And within a space of 5 to 10 minutes, the baby died. Some of the nurses that were with us ran away. The only people that stood back was myself and my matron, a very old and experienced hand. Okay, so the baby died immediately after birth. That can happen. Okay, the second one was delivered in my own hospital some years ago. This family they were more or less more enlightened. They used to have their babies abroad. So when we told them that this baby is developing abnormally, has spinal anencephaly, not compatible with life. In some cases, not in all cases, but most cases are not compatible with life. So we advised them, and they asked us to abort the pregnancy. So we induced the woman, she delivered before time, and we all saw it. That baby was developing abnormal. I'm talking about the reason why a pregnant woman must do an anomaly scan, because if you give birth to a baby that is deformed in one way or the other, that is already a red flag. And of course, that can be a loophole where you can lose your hard-earned money. Okay, so beyond that, in the course of pregnancy as well, when it gets to 20 weeks and above, there are some challenges that may crop up. I want to limit myself to just two. Gestational diabetes. This is a DM, diabetes mellitus, arising in a woman who was not previously diabetic at the beginning of the pregnancy. It can also happen with hypertension, and we talk about pregnancy-induced hypertension. This is hypertension developing in a woman that is pregnant, usually after the 20th week of pregnancy, in a woman that was previously not hypertensive. It's a different ball game if the woman was previously hypertensive before becoming pregnant. That one we call it hypertension in pregnancy, not pregnancy-induced hypertension. Now, the medical name for pregnancy-induced hypertension is actually preeclampsia. Preeclampsia is when you have hypertension in pregnancy. Usually it presents with what we refer to as triad or symptoms. Three major symptoms that you must be on the lookout. Number one, elevated blood pressure. Number two, bilateral leg swelling. Number three, protein in urine. I hope I'm not too fast. Number three is protein in urine. What you need to make a diagnosis of pregnancy-induced hypertension is to have two major symptoms. If you find a woman in the course of her pregnancy and she has protein in her urine, has elevated blood pressure, you can make a diagnosis of pregnancy-induced hypertension, and that makes that pregnancy a high-risk one. More often than not, such pregnancies don't get to term. They don't get to their EDD. They get delivered ahead of time to save the life of the woman and the baby. In some cases, it may be difficult to save the life of the baby. You may need to sacrifice the baby to save the life of the woman. That was what we were taught in medical school back in the days in OAU. Stabilize and deliver. Now, you don't want such a woman to progress from preeclampsia to eclampsia. What is the difference between preeclampsia and eclampsia? Preeclampsia is when you have pregnancy-induced hypertension, but without convulsion. The moment convulsion sets in, it makes it a medical emergency, and you can actually lose the woman and lose the baby. Okay, so you don't want it to get to eclampsia. So you need to do all manner of interventions to ensure that the woman is saved. Priority is the woman, not just the baby. We pay attention to save the container and not the content. Okay, the gestational diabetes too can come with also its own complications. The baby could become so big in the womb that you may end up having fetal macrosomia, a baby that is weighing more than 4 kg at the time of delivery. Oftentimes too, babies born to diabetic mothers can have enormous complications other than the fact that they can actually die in the womb. Okay, so there are other associated challenges that could happen. Now, when you navigate through all this and you get to a particular age, 28 weeks, that's what we refer to as age of viability in Nigerian setting. Age of viability, 28 weeks of pregnancy. That is the time when we have the capability to make the baby survive. Should the baby come out for any reason, should the baby get delivered for any reason, be it medical or whatever reason, abroad they have lower age of viability. In the US and Switzerland is as low as 24 weeks. Survivability rate at the rate which a baby can survive if it's taken out of the womb. Okay, so that's the age of viability. In Nigeria and most African countries is usually at 28 weeks of pregnancy. That 28 weeks, if you deliver a baby 27 plus 5 days in pregnancy, we'll regard that delivery as abortion, and that baby is an abortus. Okay, but if you get to 28 weeks and above and you deliver a baby, is regarded as a premature delivery. And we must do everything within our capability in Nigerian setting, incubatory care, CPAP, and what have you, to ensure that that baby survives. And we've been getting good results along that line. Okay, so when you go beyond that, the next you get to is 37 completed weeks of pregnancy. This 37 completed weeks of pregnancy is actually the one we regard as term pregnancy. That is the time that the baby is due to come out. Keep in mind that 7 completed weeks of pregnancy is 3 weeks away from the full gestation, which is actually the woman's EDD, which is actually the 40th week period that we talked about. So from 37 weeks, baby is safe, any contraction at that time, we usually don't stop it. The woman can have a baby that is alive, term pregnancy, alive and well. Now, when you deliver the baby, we'll now start talking about first, you need to deliver a healthy baby that will not have any of some of the congenital malformations I mentioned in the course of this presentation. And then there are also care that you need to give to a newborn baby. Part of the care that you need to give to a newborn baby as a mother is breastfeeding. Breastfeeding is preferred over any form of infant formula. We have a whole lot of infant formula. Some of them are pretty expensive. They are good, but they are not as good as breast milk. I must stress that point. And the breast milk, when we talk about breast milk, that first breast milk that comes out after a woman has delivered the baby, we refer to it as colostrum. It is very, very nutritious, has a whole lot of benefits to the baby, contains antibodies, contains antibiotics that could be of help to a newborn baby. So for mothers who have the capacity to do so, we usually ask them to do exclusive breastfeeding. What is exclusive breastfeeding? Exclusive breastfeeding is giving a newborn baby breast milk only without water for a period of 6 months. The only thing you can add to the breast milk is multivitamin and probably drugs for a period of 6 months. No infant formula, no other diet. Then after the 6 months, you can start introducing whatever that catches your fancy in terms of infant formula, in terms of normal feeding and everything. By 9 months, normal feeding should also set in. Now, another point I need to make here is that in some cases, a newborn baby may require some special immunization. Okay, I'll give an example. If the baby is born to a woman that has hepatitis B infection, that is why it is important that we screen every woman at the time of antenatal registration to know their HIV status, to know their hepatitis B or hepatitis C status. Babies, mothers that have hepatitis B infection, when they deliver babies, there are some certain precautions that must be done. I'll give an example. There's an injection called immunoglobulin that any baby born to a mother with hepatitis B vaccine, with hepatitis B infection must take. Is a form of vaccine to ensure that the baby does not get that infection from mother. Transmissions that go from mothers to babies are called vertical transmissions. Okay, we have that in HIV. We also have that in hepatitis infection. Okay, so you need to prevent the baby from picking the infection from the mother. Also, babies born to mothers that are HIV positive will also have some certain special care that must be given to them. There is no vaccine for that, but as soon as the baby is born, that baby needs to be put on some certain drugs. One of them is the Nevirapine for a certain period of time. Okay. In situation where you don't know what to do, once the baby is delivered, you can refer the baby to a teaching hospital or to NIMA. NIMA is National Institute of Medical Research, Yaba. Okay, they have the capacity to direct you on what to do, on how to handle babies born to mothers that are HIV positive. I also would like to mention that in some cases, if the mother has a negative blood group and delivers a baby, that baby should also have a special immunization. Okay, we call that anti-D injection. The most popular brand is Rogam injection. Okay, so that injection, just like immunoglobulin that I mentioned in the case of hepatitis B, must be given to the mother within immunoglobulin. For hepatitis B, we are going to give the injection not to the mother but to baby. But for Rogam injection, it is given to the baby. It is given to the mother, not the baby. Rogam injection will be given to the mother. The idea is if you don't give the Rogam injection, anti-D injection to the mother to desensitize her blood will form weapons against future pregnancies. So that if that woman becomes pregnant again for another time, her body system will attack that pregnancy as a foreign body, and the woman could have what we call perpetual abortion. Okay, so these are important landmarks, special areas where we need to pay attention. Okay, now when we have the baby, I've talked about the importance of breastfeeding. There's also immunization that we must have. Some immunization, childhood immunization that children or that infants need to have at some certain time. I'll mention some of them. BCG is very important. Apart from BCG, there's also pneumococcal vaccine, there's also measles vaccine, and a whole lot of others.
Dr. Bat, please, can we all put our devices on mute, please? And let's allow the facilitator only to speak. Thank you very much.
Thank you very much,
Go ahead, Dr.
my
Bat.
PDG. Yeah, thank you. So I'm talking about childhood immunization. Okay, back in the days, we are used to about 7 of them according to NPI, National Program on Immunization Schedule. And I dare say that some of them till today are still free. You can access them to private hospitals or go to local government health centers to pick them free, and it's given to patients free as well. Okay, but for those special vaccines that are usually very expensive, the mothers will have to pay for them, and then we'll get them and ensure that babies are adequately immunized. Okay, now at 1 month, when a baby is within 1 month, we refer to that baby as a neonate. When a baby is within the age bracket of 1 year, we refer to such a baby as an infant. As a neonate, there are some certain care that you also need to give to such babies. As an infant, there are some, apart from the immunization I've talked about, the nutrition is also important. I've mentioned the importance of breast milk. Now, beyond that, the most challenging time to keep a baby alive is usually the first 5 years of life. That is when they are prone to all sorts of infections. They are prone to sepsis. They are prone to gastroenteritis, food poisoning. I also want to point out something with respect to feeding of babies, feeding of infants. These days, we advise against some certain practices that used to be done in time past. A good example is feeding babies with feeding bottle. Feeding bottles are no longer advised. They are no longer in use. What is the reason? Now we have realized, healthcare workers have realized that there is no amount of washing and sterilization that can actually make those feeding bottles clean enough. Okay. In some certain situations, if you've seen a feeding bottle, if you've taken it up, you realize that there's a form of ring. That is such, the bottle is carved, has a form of ring within it. Okay. If that is actually to enable it stand when you place it, or have a good stability, probably when you place it on a table or a desk so that it doesn't fall off. If you use a brush to wash feeding bottle, there is no brush that you can use that can get to that ring that usually around the periphery. So that ring harbors microorganisms that by the time you use it again to feed baby, you may end up transmitting infection into the baby, and the baby will start vomiting and stooling. And once that sets in, and you don't take the baby fast to a hospital, if a baby begins to stool and there is no vomiting, we can advise you to do ORT, oral rehydration therapy, oral rehydration solution, ORS, whichever one that you find convenient. Okay, so that's usually what we ask you to do. And then you also give zinc. You don't give anything to stop the stooling in a child. The number of drugs out there that some mothers are used to, not many doctors can prescribe that to you because we are canvassing against them. I'll give an example. There's a drug called miskaolin. It can stop a child from stooling. We don't advise mothers to get that drug. Sorry, I will mention a brand name. Usually we avoid mentioning brand name. Diastop is not a good drug. We advise mothers against using such drug. Any drug that can stop stooling in a child is not good enough. What it does is that it stops the child from stooling. Those microbes that should leave the system are prevented from leaving the system. So what happens? The child may have abdominal distension or intestinal perforation, which if not dictated on time, can actually take the child to the theater. If it's dictated on time, the child will have to go through surgery to be kept alive. If it's not dictated on time, that child may actually die. Okay, so it's important we pay attention to that. Okay, so feeding bottles are no longer in use. What do we use? What do we advise mothers to use? For people who want to use infant formula feeding, cup and spoon. Go to a supermarket, get a special cup and spoon that your hand, a special sponge, your hand can conveniently enter into, and you wash it and dry it, ensure that it is very clean, and you can feed your baby. Some will give excuses that my baby they take my baby no fit take an only feeding bottle. It's a lie. Whatever you inculcate into your baby is what the baby will take. Okay, good. Now, there are also some certain conditions, because I talked about breastfeeding. There are also some certain medical conditions that may make us to advise a woman against breastfeeding the child. Back in the days, we used to allow babies born to HIV mothers to breastfeed their child, but that teaching has changed now. If if an individual has HIV and delivers a baby, we do not permit breastfeeding from such individuals. So the person will have to resort to infant formula. If you're using infant formula, you also have to give baby water. You have to give the newborn baby water. But if you're doing exclusive breastfeeding, you don't need to give water, because the breastfeed is about 85% water or thereabout. So there's no need for give water. When you give water, it will occupy space where the breast milk will actually take up. Okay, so you're depriving the baby of pure nutrition. So some of the things that you need to do to ensure that you have a healthy baby is to pay attention to the nutrition requirements, pay attention to the immunization requirements. And once you do that, your babies will have normal milestones. Milestones, I'll give an example. We call them developmental milestones. Okay, these are stages that babies attain depending on the age of the baby. Okay, at the first 3 months of anybody's life, of an infant's life, you expect the child, 3 to 4 months, a child that is growing normally should be able to gain neck control. When you carry that baby, the neck does not just twist to one corner or twist backward. The baby will be able to carry the neck and maintain a steady neck. That should happen between age 3 to 4 months. Okay, now it gets to some other certain stage, you should expect some sign. At delivery, the baby should have some form of reflexes. When you put your hand, a newborn baby can grip your hand with so much power. Okay, we'll talk about reflexes at birth and all that. I won't bore us with that. When it gets to a time a baby should walk and the baby does not walk, it should be concerning as well. Okay, when it gets to time that a baby should start sitting and the baby does not sit well, it should also be concerning as well. These are developmental milestones. But when you get a baby that is at age of 9 months, the weight is also commensurate to the age. At age 1 year, the ideal weight for a baby should be about 10 kg. But sometimes you see a baby at 1 year still weighing 5 or kg. In such cases, such babies may be having challenges of failure to thrive is a serious medical emergency, because it will affect all the developmental milestones. Almost the whole child, the whole entire pediatric life. Pediatric life in medical consideration is from birth to 16 years of age. Okay, so if you have a child that has grown beards and is a boy and is at age 15 or 16, as big as that child is still a pediatric, is still within the pediatric range. If you bring that child to a hospital, the child should be seeing a pediatrician. That's the truth. Okay, so I want to give some time so that I can take questions from some of the things I've talked about. Thank you.
All right, thank you so much, Dr. Bath, and I think we can have some reactions and appreciations for that. Let's appreciate him, please. Thank you so much, and thank you for keeping within our time limits. Thank you so much.
Thank you very much. Thank you very much, my PG.
All right, I'm sure some of us have learned far more than enough. I particularly picked something that is not, it's no longer something in vogue or maybe recommended for us to use feeding bottles. Wow, do I say that's almost a strange situation to me, because for me, I've always thought the best thing would be to do the sterilization and be very careful and, you know, keep sterilization. But with that now, with your own position right now, I think that's almost a new to me. I want to thank you for that. I'm sure some of us have questions, but before we ask our questions, I would like us to please quickly, if Dr. Adetunwa is set, I'd like us to quickly move into the next session so that we can have all the questions together. Can you confirm that you are online, please? Dr. Festus? I know he's online. Dr. Festus, can you join us, please? Okay, if he can't join us right now, maybe we can have questions then. If you have questions, please, can you indicate? Just indicate, please, so that you can fill some questions. You can indicate by hands up, please, so that you can fill some questions immediately until Dr. Festus is back online. Questions, please, for the next 5 minutes. Please do indicate by hand up, please.
Bio, why if people have questions, let them put it in the
CP
chat box
Betty.
now. Maybe in the chat box, they should put their questions in the chat.
Good morning.
That's an alternate, but we have
morning.
CP
Good
Betty.
morning,
You can
sir.
go ahead with your question, please. Yeah, go
Okay,
ahead,
good
CP
morning.
Betty.
My name is Rotarian Betty Elegba. Okay, I want to ask Doctor, thank you for what you've said. I got some things. Okay, my question is, why is it that when feeding mothers, that is breastfeeding mothers, when they are feeding their newborn babies, maybe if the mother is stooling, it also affects the baby. Why is it so? And how can we stop the medication, the stooling in the baby? Thank you.
Thank you very much, Ma, for that wonderful
Thank you.
question. Yeah, thank you very much. I guess I could quickly take that, or should I hang on and see if we have more questions?
Let's see if we have more questions. Do we have other people that are coming up? Any other person with question? None other. Can we go ahead with the answer, please, Dr. Bath?
Okay, thank you very much, sir. Thank you, Ma, for that wonderful question. Let me point out that this is part of the reason why a pregnant and a breastfeeding mother are prohibited or are not allowed or permitted to consume some certain agents, not just food, okay, and some certain drugs. When you're pregnant, you don't take drugs anyhow. Any drug that you're going to take, you must ensure that it's in accordance with your doctor's prescription. And that doctor must be aware that you're pregnant. And of course, how far gone the pregnancy is. I'll give an example. I mentioned the use of Fansidar as a drug that we generally use for intermittent preventive treatment when the pregnancy is halfway gone. That drug, Fansidar, is only safe within the second trimester of pregnancy. It's not safe in the first trimester. It's also not safe in the third trimester of pregnancy. So you won't say because I've mentioned it today, once you're pregnant and you have malaria, you go ahead and that is not what I've advocated though. I've mentioned that it's safe only within a certain period. Ditto for other drugs. So some drugs that women, breastfeeding mothers take can actually affect even pregnant mothers. Some drugs that they take, usually without doctor's advice, can actually cause jaundice in the baby. One of the causes of jaundice is traceable to drugs taken by mother towards the end of their pregnancy. It can actually cause jaundice in a child. Okay, I don't think I talked about jaundice. That's one of the things that we also need to look out for when a child is delivered. Usually we do the test 2 days after delivery and again repeat about 5th or 6th day after delivery before the baby's naming ceremony. Okay, but what you consume in terms of food or drugs can affect your baby. So if you take something that can make you purge, it can make your baby to purge as well. But when the baby begins to purge, the best you can do as a mother is rehydration, rehydration, rehydration. And what do? You give oral rehydration solution with zinc. That's the most you can do. If the child is vomiting and not tolerating orally, you need to take that child to the hospital. You don't give anything to stop the child from stooling. Thank you very much.
All right.
Thank you, sir.
You're welcome.
Good morning.
Yeah.
Good morning.
Good morning. My club, my Rotarian member.
Good morning.
All right, thank you very much for
my
that.
Rotarian change maker president. Can I
Thank
take
you
my
very much.
question?
Yes, you can.
Yeah, go ahead. Go ahead, Adebolanle.
Good morning. I'd like to thank God you actually pronounced that of jaundice. because I could remember when I had my second daughter, in the course of the pregnancy, there was no traces of jaundice, and then even after the delivery, but 2 days to the naming ceremony, there was serious case of this, which was treated. However, I was going to say that in the first 3-6 months of breastfeeding, is it advisable that you can breastfeed your baby all through without adding any other supplement? What I mean supplement, like formula. And yet that baby still had jaundice. And the jaundice was close to like 3 months before it was clearly eradicated. So my question is, in the course of that pregnancy, there was constant doctor's care, there was constant medication, and there was no traces of jaundice until the delivery of that child after a week. So how would you advise mothers that are still in that state? How do we eradicate jaundice? Is this something that can be eradicated even after delivery, or is it being detected during pregnancy? Then, second, what precautions will you tell mothers, especially those that say strictly do breastfeeding for 6 months, but yet they still contract one ailment or the other?
Can you repeat your second question? I think there was an interference in the background, so I didn't get that. What advice will I give mothers? Come again. Just the second aspect of your question, ma.
Okay, it is strictly breastfeeding for 6 months without any other baby formula feeding, but yet there are still traces of jaundice, even in children, in infants between that range of time. So what will you advise us, mothers that are breastfeeding and they are strictly 6 months breastfeeding without any other formula, but yet that child will still contract one illness or the other?
Thank you very much. Thank you very much for those wonderful questions. Okay, let me also say this. Jaundice is a major topic in medicine. Okay, I was tutored by, we were taught in medical school jaundice by Professor Owa, famous Professor Owa, who wrote a book in jaundice in University, OA Obafemi Awolowo University. Now, jaundice is a medical emergency. You can't dictate jaundice until the baby has been delivered. So it's not something you can actually dictate in utero. Abroad, they may have the capacity to do so. But in Nigeria, we only dictate jaundice usually 2 days after delivery. Okay, and let me point out that different classification of jaundice. Okay, so, but the two major ones is physiological jaundice and pathological jaundice. So some jaundice may not require any intervention. It will go on its own. But if it is pathologic jaundice, you need to do an intervention. Okay, good. Now the intervention, okay, the clinical signs. Let me start with the clinical signs. What will make you know that your baby has jaundice? Usually the healthcare workers that you actually pick it out. But standardly, most hospitals will run tests for jaundice at the second day of life of that baby. In my facility, once the baby is 2 days old, we'll take the baby's blood sample for full blood count, for serum bilirubin, that's the test for jaundice, as well as blood group. Genotype won't be possible until the child has attained 1 year of age. Okay, good. Now, the jaundice can present with yellowish discoloration of the eyes. But first of all, to aid our understanding, what is jaundice? Okay, jaundice is a medical condition that could happen not just in babies, but also in adults. Yeah, a medical condition that
Dr. Yusuf, can you mute yourself, please? PJ Yusuf, can you please mute yourself? Thank you.
Thank you very much. A medical condition that has something to do with the liver majorly, which presents usually with yellowish discoloration of eyes as well as the skin. It could be in baby, it could be in adult. So, but we are concerned this morning with neonatal jaundice. So let me specify that now, because an adult can actually have jaundice. Jaundice, once your eyes are discolored, you can pick out jaundice. So there are a number of ways that we could pick out jaundice in a child, not just from the yellowish discoloration of the eyes. We can also pick out jaundice from the skin. when you write a letter B with your hand on the skin of a baby that has jaundice, maybe on the abdomen, that letter B will stay for a while before it disappears. That's an indication that the baby has strong jaundice. I also dare say that to look out for jaundice, you need to inspect the baby's eye under normal light, not bulb. You need to bring out the baby on the daylight so that you can have a clear visibility. Okay, but the most important thing to do is to have a test, serum bilirubin, done for that baby. Okay, so if you do it and the level is below 10, usually you don't do any intervention. 10 milligram per DL for both total bilirubin and indirect bilirubin. You don't usually do any intervention. But once the level exceeds 10 milligram per DL, intervention will need to start in form of phototherapy. And I also want to point out that the treatment of jaundice does not extend into the entire neonatal period. Phototherapy can only happen within 2 weeks of delivery. So once it goes beyond 2 weeks, 14 days, you need to use some other treatment for jaundice. And jaundice can actually damage a young and immature brain of a baby permanently. A baby can be canicteric. That's a complication that could happen if you don't pick out jaundice and it damages the baby's brain. It's called canicterus. So the baby can become canicteric. Okay, so it's a medical emergency. What do we do to treat jaundice? We put the baby under daylight or in the hospitals under phototherapy. And once we do that, we monitor the serum bilirubin on daily basis. You must be checking the serum bilirubin to monitor whether the level is going up or going down. In cases where the level is going up, even after you've commenced phototherapy, it could go as high as 20 milligram per DL. If it gets to 20 milligram per DL, you have to deploy a treatment option known as exchange blood transfusion, EBT for short. Okay, we do that a lot in my facility. Because these days the level of jaundice is on the increase as a result of a whole lot of things. We may not have time to talk about some of the causes of jaundice, but I'll mention one. One of them is when you have blood mismatch between the husband and wife, resuscitation immunization. But let me talk about the one that we can all be familiar with. There are some agents that you don't bring around a newborn baby. Something like camphor, the one we use sometimes we drop it in toilets, we drop it in our boxes. Camphor is not good. Any newborn baby, you shouldn't bring it close to any newborn baby. It can cause jaundice. Apart from drugs that mothers took toward the end of their pregnancy, that can also give jaundice. There are a whole lot of other causes of jaundice. There's also what we call Kefa hematoma. When the baby is coming out from the birth canal, the baby could have some injuries to the okay, which could actually be tension will have to be fast and is within a certain period. It doesn't go beyond 14 weeks, 14.
Fellow veterans, I think we've lost the speaker. If you all can hear me, can you please indicate?
Hello.
Can hear you. Can
My
hear you.
PGB.
All right, perfect. Okay. Anyways, I'm sure what we've learned is just so much already, and I want to thank Dr. Bartholomew all over again. And it's on that note, I quickly want to call on one of us again also, another past assistant governor, Festus Adetonwa, who will lead us on what Rotarians can do, the possibilities of Rotarians just folding their hands are there, but we want to know what Rotarians can do, what intervention Rotarians can do. So Dr. Festus, please, I know you are in the middle of an emergency right now, and I want to thank you for still ensuring that you want to deliberately take time off so that you can have this with us. In under 20 minutes, can you please take the floor? Dr. Festus, please.
Okay, thank you so much, my past district governor. Special recognition to the district governor on the call and every other Rotarians on the call. Let me first of all appreciate Dr. Bates for doing justice to that topic. Kudos to you, sir, Dr. Bates. Yeah.
Thank you very much, my colleague.
Assignment is very straightforward. It's what concerns us as
President
Rotarians
Kepani.
in supporting the development of child and maternal health. So my topic says possible interventions of Rotarians on child and maternal health development. I would have loved to share my slides, but I was trying to do that from here, but I can share with the coordinator at the end of the day. I start with the first slide by saying, do you know that healthy mothers, thriving children, gives a stronger communities? Do you know that healthy mothers, thriving children gives a stronger communities? I quickly like to give us why we need to actually be concerned as Rotarians with the issue of child and maternal health. I'm sure Dr. Bat might have mentioned a lot. We are having up to over 500 deaths per 10,000 live births. That shows a lot of deaths are being recorded during delivery. And about 39 deaths per 1,000 live births among the neonatal mortality now. For every child that is born within the first 28 days, we have a lot still dying. And children under 5, we have a lot of them still dying. And this is showing a concern to us as Rotarians, as we are known to have passion to save life. What are the common leading causes? I would not want to bore us, Dr. Pat has said a lot. Postpartum hemorrhage, bleeding after delivery, infections, hypertension that is not well managed, malaria in pregnancies and in children, malnutrition, you mentioned it, poor access to skilled health care is also a factor. What is the Rotary Global Focus as it concerns maternal and child health? Our as Rotarians throughout the world is to ensure we reduce maternal and child mortality. When I say mortality, I mean deaths. Improve access to quality reproductive health. Support health workers and facilities. Promote nutrition and disease prevention. That is a Rotary Global Focus area. We Rotarians that people need to be people of action. We want to ensure that families are healthy. And what are the possible areas by which we can improve the development of child and maternal health? I put them in different focus areas. I said focus 1. As Rotarians, as clubs, as districts, we can look at system development support in terms of child and maternal health. And what are the likely things we can do in this area? Number 1, we can support the health system by equipping the primary health center that is the closest to all our communities with maternity equipment, delivery beds, blood pressure apparatus, vital Dopplers, things that are used to measure the baby when the pregnancy is developed, mentioned in the other time. We can support by providing solar power. We know the issue of electricity in the country. We can support by providing solar power for them. Make available sources of water supply for 24 hours in the maternity center. We can renovate labor wards. We can renovate labor wards, rooms, and postnatal wards, so that our people going to deliver, they have a good place to have a delivery where they can be well assured. And that is one of the reasons you see that most people, some of us here, we might not want to go to public facilities to have a delivery. But how long are we going to keep doing that? Is it sustainable? So we can also support the government by making the government facilities to be accessible and in good condition for people to deliver. We can support by donating ambulances for maternal referral system. One of the major challenges in maternal and child health in the world today, and especially in Africa and Nigeria, is access to good health facility. And Dr. Bat mentioned it the other time. One of the ways by which we can attend to this as Rotarians is by supporting the provision of ambulances. We have those ambulances In fact, throughout the world now, tricycle ambulances have been encouraged. This manual ambulance that will be fashioned in a way that can carry people. Because in the extreme communities, in the local area, in the rural areas, in the villages, people are in labor. They needed maternal support and child health support. It might be that the provision of these tricycle ambulances will be the one that will be available to easily carry them to the nearest facilities, which has been debarring them over the time. Free antenatal outreaches we can organize for them. Make available scans and laboratory facilities, equipment in the lab for them to do antenatal screenings. All pregnant women are expected to have antenatal clinic about 4 times. We can distribute mama kits, clean delivery kits, sanitary pad, mosquito nets. These are part of what I expected of us as Rotarians to support. We can also go a long way. We can also go a long way training the community, the community workers, safe delivery practices, or safe delivery practices. And how can we do this? We want to they've been involved in building the capacity of health workers throughout the country. The maternal and child health issues. We can key into the program they have been doing over the years as clubs and Rotarians to support the development of child and maternal health in Nigeria. This support. Somebody was asking about breastfeeding the other time. These are things we can use as Rotarians to support the improvement of child and maternal health in the country. My second focus focuses on the child health, immunization, and nutrition. Dr. Bart mentioned malnutrition as part of the factors, risk factors, that is leveling the maternal and child health mortality in the country. As Rotarians, we can do this. Thank God, our moderator, our coordinator, has been championing Rotarians for family health days and HIV for many years. This is an avenue for us as Rotarians to support the improvement and development of maternal and child health in Nigeria. Ensuring immunization are made available for children on the front, ensuring they have the administration of vitamin A. We can support them by ensuring that the growth monitoring nutrition screening, because we have a lot of children that have what is called stunted growth. They are not growing according to their age. We can support the primary healthcare system by ensuring that they have good growth monitoring and malnutrition screening for the children during any clinical attendance of any child through the mother or the caregiver. We can support the warming campaign that in schools that have been organized by the federal government and the state government. This will ensure that, because one of the things that will showcase malnutrition easily is worms. If children are having worms, so we have a lot of deworming programs organized by State Ministry of Health, in which they can ensure that children have access to the deworming drugs. We can support this program as our Rotarians. We can promote exclusive breastfeeding by ensuring that you go to community, go to antenatal clinic in the permanent center. To us to enlighten them and educate them. My third focus is on health education and community awareness, as I mentioned earlier. Notice says to talk to people on danger signs in men. It's not, when we talk about maternal and child health, it's not about women alone. That's what we call a male champions for maternal health now. We can organize a program and support our women during pregnancy, during labor, during delivery, and in monitoring our child as they grow. We can ensure this. Adolescent health talk is also an area we can come in with. We can support by having menstrual hygiene talk for our adolescents age group in schools, in the community. We can support them with sanitary. You'll be surprised that we still have a lot of adolescents using clothes as pad during they are doing their menstrual period. It's still as bad as that. As Rotarians, we can champion this aspect. We can encourage family planning, which will improve maternal mortality and maternal health. Jingles are there, market sensitizations are also there. As Rotarians, we can do that. The federal government has come up with a program called MAMI program that talks about maternal and neonatal innovation initiatives. We are made available to ensure that ambulances are available for every children under 5 and pregnant women have easy access to the facilities. We can support this program at the state level, local government level as Rotarians and as clubs. And the third focus will be one of our areas as well, which is talking about WASH and infection prevention and control. You can go as Rotarians as a club, as a district, to ensure that in all health facilities, we install washing stations in all our maternity wards, so that healthcare workers have access to wash their hands. And even the mothers, they wash their hands, which will go a long way in ensuring infection control among the pregnant women. We can provide the infection control materials, gloves, disinfectants, and waste bin in the facilities. And also we can promote sanitations in home to prevent diarrhea in under 5 children. Dr. Bat talked about diarrhea. And we're talking about the drugs we engage in. As Nigerians, as Rotarians, we should be promoting preventive measures than curative. Curative is not there 100% any longer. Most people don't know how to go about it. It's better for us to promote to prevent those things. So we can promote sanitations among the other 5 children, enlightening the community and the school children. Don't forget that there is this slogan that says, clean environment equal to safer mothers and babies in the community. My fifth focus talks about mental social support for our pregnant women, mothers and children, mental health and social support. We can ensure that we are as Rotarians to prevent depression. There's what they call Yoruba. Recently, somebody that just delivered, they started misbehaving. They will say it is one diabolical things or whatever. These are things that we can look into to ensure that people are enlightened and aware and measures to take to prevent all this. Counseling services, we can support them. A lot of young mothers, young children, young ladies getting pregnant. At the end of the day, we realize that they go and dump the baby inside the stream in the community or beside the roads in the dark of the day. So we can support them with economically for them to have a means of living so that they can take care of that child. Whether they try for it or not, only God knows. They have the answer to give. Child protection advocacy and early childhood development program, we can champion it as Rotarian. Child protection advocacy, we can champion it. That there will be a legal backing and policy that protect the health of the child. That is, as a mother, as a father, you have that obligatory role to take your child out to health, to seek and health care. So as to improve the seeking behavior, we can champion it as Rotarians. My sixth focus will talk about the data advocacy and partnership. One of the challenges we have in the country today is we don't have records. How many people are giving birth? How many deaths are we recording from the birth? How many children do we have? How many children under 5 are dying? We don't have data. So we can advocate for health management information system. We can support this provision of registers, printing of registers in the facility, so that adequate data can be captured to give us a good maternal and child health improvement. We can leverage on action groups for maternal child health. We can leverage on them supporting the facilities regularly. And how can we achieve this as Rotarians? Practical tools by which we can use to achieve it. Number one is through the family days, as I've mentioned, we can integrate into it. You can integrate to it. The second one is we have district grants. As well, you can access the district grant for small and quick impact local projects. You can access it to do all this. We have the global grant that can give us a large and sustainable project to $400,000 about per it. So as a club, as we can access the district grants, the global grants, and the Rotary family, we can achieve this through that. The second aspect, we can do corporate partners. We can partner with them in the name of ensuring that our child and our children and mothers have access to good health care. Volunteerism, we have Rotarians in the diaspora that are coming to the country. We can support by ensuring we have outreaches for medical missions so that this can be improved by all means. There are other several projects in the country we can key into. Safe mother project, a 2-10 PLC showing 50-minute drives, immunization and nutrition for 5,000 children on the field, hotel and toilet in 20 maternity centers, Medicare too. What are we going to achieve as Rotarian? The time we're able to do this, the time we're able to do it, there will be more skilled deliveries and fewer maternal deaths. Immunization coverage and elder children, better nutrition and reduced stunting, stronger resilient health system, sustainable development goals. 3, which says good health and well-being. Which as Rotarian, let us serve. It means serve, SERVE. S stand for support the health facilities, or E stand for educate the communities, or E stand for reach mothers and children, and V stand for volunteer and skills. E stand for engage partners. And then by saying this, together we can ensure no mother that is giving less life and no child that is from a preventive cause. And look at it. It's Rotarian. We can ensure that together there will be no mother death while they are trying to give birth to life, and that no child will die from preventable causes. These are my little presentation this morning. Thank you for listening.
All right, thank you so much for that. Past Assistant Governor Festus, and I'm sure we can appreciate him. Let's appreciate him, please. Thank you so much for that. Yeah, thank you so much. I want to thank you especially also. I know you are in the middle of an emergency right now. Something happened during the week to which you had to present. It really caused some like fellow Rotarians, please. Thank you so much for that appreciation for Dr. Festus Sanwa. Now, quickly, without wasting so much of our time, can we ask questions? If we have questions, let's fill the questions right now. Indicate by hand up so that we can recognize you and ask you for the question. Questions, please.
Always remember that when you walk in the dark, when you are alone, you're never alone. All right, God has sent his angels to watch over you, to keep charge over you in all your ways.
Let us mute our devices, please. Let's mute our devices. Let us mute our devices, and if there are questions, let people indicate by a hand up, please. Rotarian Linda Chinwe is there. You can please mute. Thank you very much. And Rotarian Patricia also, can you please mute? Thank you. All right, if you have questions, please. Questions? Okay, I can see appreciations in the chat room. No questions yet. All right, fellow Rotarians, I think in the absence of...
My DLS.
Okay, PJ Yinka.
Yes.
All right, PJ Yinka, please. I can see a hand up. Okay. PJ Yinka Deoshun, you have the floor.
All right.
Go ahead, please.
Okay, thank you very much, my PDG. Good morning, fellow Rotarians. My own is in form of a request. May I know if it is possible for us to have the soft copy version of the presentation made by each of the two facilitators? Thank you.
All right, I think that's a possibility. It's possible we'll request it and share it. Thank you very much. Any other requests or question, please? Or maybe there is something anybody just need to add. Some of us have learned new things around here, and I'm surprised about some of the things I'm hearing. It looks more like you know it all, and suddenly you're hearing it from people that are researching on a daily basis. Questions, please, because in the next 5 minutes, we should just conclude on this session. If there are no questions, any question, any suggestions, any comments? All right, if there are none, may I once again thank everybody for being part of this first session. And I'm particularly excited that we're able to have as many people to join us this early Rotarians won't stop working. That's what that tells me. And I know it's because we all want to create that lasting impact, which we all have started this Rotary year. Once again, I want to thank you. Madam DG, I don't know if Madam DG have a parting shot for us before we call this to a final end, or if any of the learning facilitators. Okay, Madam DG, please.
Thank you. Thank you so much for that. I want to thank all the participants online. Thank you so much. Most importantly, a special thank you goes to our facilitators for sharing their experience, knowledge, and personal and practical insight with us. Thank you so much. We appreciate your time. Now, as we return back to our clubs, I encourage you to ask one simple question. And that question is this: what can my club do differently because of today's discussion? You know, whether it is organizing antenatal support programs, promoting immunization, or even providing clean water in a community that has no water. Or even maybe it's just merely educating mothers in our communities. Every action counts. And before we sign off this morning, please remember that our work as Rotarians does not stop when this meeting is over. Every day presents yet another opportunity to make a difference in somebody's life or even in our community. So I want to thank you so much, our facilitators, and of course the DLF for organizing this. You know, this is so important that I believe that every Rotarian should join in. Going forward, I think we will change this to an evening program, which would allow, even if it is just 50% of our members to join in, because this session is so important. It is imperative that we get Rotarians to stay tuned to this. Thank you so much. Together, let's continue to create lasting impact. Thank you, and God bless you all.
Thank you so much for that parting shot, Madam DJ. Fellow Rotarians, as we crawl gradually to the end of this session, somebody just asked, Linda, you didn't ask earlier, but just so to attend to what you have sent, what indicators should we use to measure the success of our maternal and child health projects? What indicators? I don't know if any of our facilitators are listening, and if any of them can just quickly support us with that quick answer to that. The question is, what indicators should we use to measure the success of our maternal and child health projects? I don't know if any of my facilitators can quickly take that for us. Dr. Bath, are you still there? Dr. Festus?
Thank you, my
Dr.
PDG.
Festus, Dr. Bath?
Yes, thank you, my PDG.
All right, thank you so much.
That's a very good question, but studies that pertain to health issues are usually based on conducting something like a survey. So it may be difficult to do at this time. I'm not sure if we have done any survey to actually know determine the impact. And usually you must have your sample size, okay, so that you can have respondents probably in the communities where we have carried out such exercises in the past, or even while it is ongoing, so that we can have a proper assessment. So I can't think of picking up anyone at the moment, but in government circles, we have a whole lot of such indices that are usually used. For instance, the death rates is a major indication. You can use that to assess the healthcare system of a particular community, usually under 5 years of age. So that's one of the major indices. Thank you very much.
All right,
But
thank you
with
very
respect
much
to
for that.
Rotary, I
My
don't think we have
DLF,
any who can lay hands on
my
them.
DLF,
Okay.
my
Madam DG
DLF,
mentioned it all.
my DLF.
Madam DG.
Okay.
Go ahead,
Now,
please, Madam DG.
concerning how to measure impact for clubs, I think clubs should look at the number of beneficiaries they have served, community satisfaction with that particular project, number of referrals they made for specialty care during that particular project. Then they look at partnership with established government or agencies or healthcare providers. Those are things that we can use to measure impact as Rotarians during our project. Thank you.
All right, thank you very much for that, Madam DG. Maybe I should qualify you also as a doctor. Well, professionals on this call will not so much love that, but at the same time, you just have done justice to that question also. So I want to thank you also for that, fielding that question, Madam DG. Every day is a day for us to create lasting impact, fellow Rotarians, and child and maternal health cannot stop. As long as there is humanity, women are giving birth on a daily basis. Ladies are getting pregnant on a daily basis. The mother needs to be cared for. The child also needs to be cared for. Fellow Rotarians, let's create that lasting impact in the life of these mothers, in the life of these children that are coming into this world. The maternal month cannot stop today. It's a yearly thing, it's a daily thing. All of us must be aware of it, all of us must communicate to people, and we must ensure that we create that impact this Rotary year. And so on that note, fellow Rotarians, I'd like to call this to an end. And once again, thank you for joining us in this first edition of the learning series for this Rotary year. The next one is going to come up in the next couple of weeks, and I want to invite you in advance to be part of it. Please invite somebody who will eventually invite somebody, because knowledge cannot stop. Fellow Rotarians, once again, I thank you as I drag this to a final conclusion. Do have a lovely weekend and have a wonderful Rotary year. Bye for now, everybody.